Hello, I'm Dawn Ward and I work as a retail pharmacist in a rural area, an area with predominantly an elderly population. Along with my dispensing team, I've experienced new and challenging ways of working during the Covid-19 pandemic, because most of my patients are shielded and vulnerable. It's become obvious over the months that the face of primary care has changed considerably and difficult decisions are having to be made. In the course of my work, one specific issue has raised concerns, and that is the use of Do Not Resuscitate orders, commonly referred to as DNR forms. This presentation will briefly look at the rationale behind these forms, their use during the current pandemic, and public concerns that have been raised. Different ethical views will then be considered. DNR refers to an advanced decision made by medical staff not to attempt cardiopulmonary resuscitation, CPR, on a patient who has stopped breathing or whose heart has stopped. In medical terms, when a person is suffering respiratory or cardiac arrest. Healthcare professionals normally start discussions about resuscitation if a patient's at risk and suffering from multiple health conditions. It is often deemed appropriate for terminally ill patients where it is considered all treatment options have been exhausted. Unlike the experiences seen on television, resuscitation for many can be an invasive and painful procedure. It can, in some cases, prevent a patient being surrounded by family and friends in their final moments. There are three main circumstances in which the law allows DNR decisions to be made. One, where a patient with capacity asks not to be resuscitated and their request has to be respected. Two, where a doctor considers that resuscitation is likely to be futile. And three, where a doctor considers, having had full consultation with the patient, that the burden of CPR outweighs the benefit to the patient, and the patient is likely to be left with a poor quality of life. All decisions should be made on an individual basis, and there should be no blanket policies. However, a point to note, the law does not require the patient's consent for a DNR order to be placed on their medical record. Yet in the midst of the Covid-19 crisis, concerns are being raised by several organisations. Age UK is just one organisation reporting that older people are being pressured into signing DNR forms. In an article published in April of this year, Age UK responded by saying that they are seeing shocking examples where blanket decisions seem to be made about the care and treatment of elderly and vulnerable people. People have felt pressured into signing and agreeing to DNR forms without time to consult their families. Age UK also stated that many people affected have experienced fear and anxiety and feel that their lives and wishes do not matter. In many cases, it is the family of these elderly people who are raising concerns. The British Institute of Human Rights has reported that care providers in Somerset, Derbyshire and in East Sussex have been contacted by GPs to say that they deem the people they support all should be DNR. These particular care providers work with people with learning difficulties. This then raises concerns for people with dementia. Speaking personally to a GP, I was told that elderly people with underlying health conditions were unlikely to be placed on a ventilator if admitted to hospital with Covid-19 because of limited availability. It was deemed more appropriate for them to be treated at home by their own GP. And because of this, it was necessary to speak with these patients about DNR forms, particularly if they had several underlying health conditions. But due to the Covid-19 situation, this is usually by means of a telephone conversation rather than face-to-face, which you can imagine with elderly patients raises concerns in itself. A Bristol doctor stated in the media, "When faced with a choice of how to use limited healthcare resources, we face drastic choices. Save the people who can most likely be saved, this is a clinical judgment, or save the people whom we deem to be most worthy of saving, social value." He stated that surely it was better to make these decisions based on clinical judgment about a person's likelihood of benefiting from treatment than to pick and choose who survives based on how valuable we think their lives are. But this is still very much a matter of choosing the lesser of two evils. It has been noted, however, by the media that anybody who has a DNR report placed on their medical record is less likely to be placed on a ventilator if admitted to hospital. So are we left with an unanswerable dilemma? How would this be viewed ethically? If we consider what Immanuel Kant terms the practical imperative, then the above decisions are brought into question. Kant states that it can never be right to treat people just as a means to an end. Human beings are always ends in themselves, and Kant even describes human beings as holy because of this. It can never be right, therefore, to use human beings as a means to the end, or treat any group of people as a minority that doesn't matter. This principle enshrines the idea of equality of each and every human being, irrespective of class, colour, race, sex, age, or circumstance. So to pressure elderly people into signing DNR forms to protect the availability of respirators and ventilators for others would appear, in Kant's view, to be wrong, even in the current pandemic. By so doing, we are preventing the person making their own rational decision. If we look to utilitarian ethics, however, this is generally thought of as a moral theory summed up by the phrase, "the greatest happiness for the greatest number." On the surface, it would appear that utilitarian ethics might support the use of DNR forms. It could be argued that an elderly person is less likely to survive Covid-19 than a younger, normally healthy person, that the elderly person has lived their life, and many of their contemporaries may have died already, and quality of life is probably restricted. On the other hand, a young person has a better chance of survival and probably a better quality of life. They may have a young family which relies on them for support, and they may work and contribute much to society. I think we may have to agree that the utilitarian approach does have problems, however, because it relies on predictive values. And there is the big question of how do we define happiness and how do we quantify happiness? We are all aware that medical procedures can have unexpected outcomes. The elderly person may have years left to live, whilst the young person may not survive Covid-19, regardless of being ventilated. A younger, healthier person may contribute nothing to society, whilst the older person may be very active in their community and have much to offer. From a Christian point of view, how do we know what counts as just allocation of healthcare resources in a particular situation? What is justice for one patient and not another? According to Neil Messer, perhaps we should look for themes in the Church's tradition, stories from Scripture, insights into what the Christian tradition means when it says justice. In the Sermon on the Mount, Matthew's Jesus paints a picture of a God who is indiscriminately generous to all, whether they deserve it or not. Divine justice, according to this text, doesn't seem to mean simply giving people what they deserve. It's good to note that one highly important practice of the first followers of Jesus was to share their goods self-sacrificially with those in need, and this sharing didn't seem to have geographical limits or boundaries. According to Samuel Wells and Ben Quash, growing old is a challenge to universal ethics because it pushes against rationality and autonomy, and arguably some of the most marginalised persons in society are there not because of their race or class or gender, but because of their age and infirmity. And John Swinton seeks to develop a practical theology of dementia because he believes these are a group of people whose voices are lost, ignored, or silent. Swinton redescribes the stories of people with dementia within the larger counter-story of God. Human identity and value are rooted not in our capacities, but in the God who created and sustains us. As his book's subtitle claims, we live in the memories of God. It has to be remembered that people with dementia remain a person right up to the point of death. They are held unconditionally within the love of God, and even if they do not remember him, he remembers them. Yet evidence has shown over the last few months that it's the elderly, those with learning difficulties and dementia, who are being asked, pressured, and in some cases without consent, having DNR orders applied to their medical records. This cannot be ethically correct. Healthcare will be faced with tragic choices. If we cannot do all the good things that need doing, the choice of one good is also necessarily a choice against another. One ventilator, two patients. Choices have to be made. The DNR forms, to quote the Bristol GP, the lesser of two evils. I believe as Christian communities, the present pandemic forces us all to think about healthcare resources and healthcare allocations, and probably to challenge political influence. But there is much to be done for the future. Thank you.